Hey, good morning, everyone. Thanks so much for being here. I'll kick us off and get us started. I'm Jason Jabari. I'm the faculty director at the Clark Fox Policy Institute at the Brown School at Washington University. On behalf of our team, I want to thank all of you for being here. This is a packed room, and it was packed at 8:30 on a Tuesday, so kudos to you all. Thanks so much for being here. We're really excited to have you. I think one of the things I'm most excited as when I look around the room, we have a great mix of researchers, practitioners, advocates, policymakers, and all sorts of community partners that have come together. The conversations I've kind of walked around and have been really riveting. So again, this is wonderful. As a former teacher and college professor, it's so great to see a packed room with no laptops open and people engaging in genuine conversation. So really just like this has been an incredible start to the morning. So I'm just going to give some brief remarks. I'm going to talk a little bit about our initiative. I'm going to talk about why you're here today, and then I'm going to kick it over to Dr. Ferris. So this is part of the Clark Fox Policy Institute's Senior Scholars Fellows Initiative, and our goal here is pretty straightforward. We're trying to bridge the gap between research and policy and community by supporting scholars as they translate evidence into practice and as they work to take that practice and move it into the policy space as well. Our goal is really around child, family, and community well-being. And again, we're not just investing in research here. Really, we're investing in the partnership, the work that it takes to translate evidence into practice, and the work that it takes to lift those practices up and take them into a local, state, or federal policy arena. So today is a wonderful example of that mission. So food as medicine has emerged as one of the most exciting and rapidly growing areas of innovation. In the policy space, it intersects health, nutrition, public policy, education in some cases as well. And across the country, we have healthcare systems, policymakers, researchers, and community organizations increasingly recognizing the important role of food that plays in preventing disease, improving health outcomes, and reducing healthcare costs. While national attention to food as medicine continues to grow, we know that much of the expertise in this area is right here in the St. Louis region. And that's why we're really here today. And that's why we're really excited to be able to bring you all together. So right here in St. Louis, we have organizations that have spent years developing creative, community-centered, equity-focused ways of addressing food insecurity and advancing health equity through food as medicine. Today's event is an opportunity to learn from that expertise, to share that expertise, and to explore emerging research and policy developments and strengthen the partnerships right here in our region, which is needed to move that work forward. I want to do a few quick thank yous here. First, I want to thank Stephanie right here. Stephanie does all the work behind and in front of the scenes, so she's an incredible asset. All the things that go well are due to Stephanie. Anything that goes poorly, that's due to me. So thank you, Stephanie. I also want to thank all of our co-sponsors. So we have the Center for Social Development, the Public Exchange, the Confluence Collaborative, the Center for Diabetes Translational Research, and the Institute of Clinical and Translational Sciences, and the Bursky School of Public Health, Food, and Agricultural Research Mission. So a lot of co-sponsors here. Let's give them a round of applause. So thank you for that. And now it's my pleasure to introduce today's Senior Policy Fellow, Dr. Dan Ferris. Dan is an Associate Professor of Practice at the Brown School and Co-Director of Policy Education and Practice at the Center for Social Development. Throughout his career, he has worked at the intersection of research, policy, and community engagement, helping connect evidence to action on issues including food insecurity, health, and economic well-being. Dan's work embodies what the Senior Policy Fellows Initiative was designed to support. He is deeply committed to ensuring that research informs real-world outcomes and that community knowledge and lived experience remain central to the policy conversations. That commitment was recently recognized through a Provost Impact Award from the Confluence Collaborative for Community Engagement, which honors faculty members and community partners whose collaborative work creates meaningful and lasting impact across the St. Louis region. On a personal note, Dan was one of my first friends as an employee at Washington University. He was also invited me into some food work for the first time. I think we had many long rides to OFS, and then we also went to Normandy and did some work as well. So Dan has been a dear friend of mine. He's also glowing from the New York Knicks win. So kudos to Dan for all of that. And again, we're so grateful that Dan is a part of our community and that we can be with him here this morning. So without that ado, thank you, Dan.
Yep. Hey, good morning, everybody. This is a full house on a Tuesday morning. We can do a little bit better than that. Let's try it one more time. Good morning, everybody. Thank you. Take out your bingo boards. You can check off New York Knicks reference already for the time that we've got. Thank you, Jason, for the gracious introduction, to Stephanie for all the incredible work, to a room full of amazing colleagues, past, present, future. It felt a little bit like being at a wedding, kind of going around table to table and getting to see everybody and say hello, which is such a gift. So it was almost about a decade ago, on one of the coldest days on record, in a conversation with Trina Reagan, that I was first really introduced to this idea of food as medicine and the way that it's currently been institutionally embraced at a really rapid rate. So now fast forward, and I'm so pleased and thrilled and honored and humbled in all the words to be serving as a bit of a convener this morning along with the Clark Fox Policy Institute and with an incredible group of panelists. So my job this morning is to do a little bit of stage setting, what some of my colleagues would call the jazz hands. So I'll try to keep that part of it brief, but then while doing some stage setting, very sincerely wanting to move us into the conversation, which is going to be dynamic and center some pretty incredible perspectives, expertise across research, policy, community, and practice. Dramatic pause for the clicker. Okay. There we go. So just as we're settling in and starting to think about some opening ideas, moving from the small talk, the tall talk that we were making, our good cup of coffee, our fruit salad, our Danish. What is food as medicine? There are countless interpretations that have emerged and that are being understood and advanced. And most importantly, none of them are definitive and none of them are precise. They are evolving rapidly, just as the conversations are. The Tufts University Food as Medicine Institute just released a toolkit yesterday on food as medicine implementation, evaluation, and design, and describes food as medicine as representing a range of foods-based interventions, treating diet-sensitive health conditions, reducing health disparities, integrated within the healthcare settings. The Office of the Assistant Secretary for Health does a little bit of similar heavy lifting and talks about access to nutritious food from a systems level. This idea that it's also supporting production of and facilitating access to nutritious food across a health continuum and range of settings. So I was imagining the room of people this morning, and when thinking about what is food as medicine, I haven't done an exact head count, but we'll say 110 people. 110 amazing people in this room, and 110 maybe adjacent, maybe overlapping, maybe quite distinct interpretations of what is food as medicine, and most importantly, how do we move it forward? So food as medicine has experienced a rapid institutional embrace in recent years, with federal agencies, healthcare systems, philanthropy all increasing investment. The inaugural National FinCon, our Food as Medicine conference, was earlier this month, and along with this morning is right up there with Taylor Swift, New York Knicks playoff tickets, and other hot ticket items in terms of how hard it was to get into a national convening for food as medicine. There's both incredible demand and opportunity, and then also some challenge as this space quickly adapts and evolves. So the food as medicine field is crowded and growing fast. It makes me think of one of my favorite memes of conversations that we have recently about food as medicine. When we move into a space, all of a sudden it's a buzzword. Everyone's talking about doing food as medicine, doing food as medicine, doing medically tailored meals, produce prescription programs, and everything in between and beyond. Lots of organizations are connecting to or claiming the label of food as medicine. And what we'll hear today are some foundational, decades-long approaches to food as medicine that have really set the standard in terms of how the evidence has been built for these programs. Definitional ambiguity and competing values are both challenges and opportunities. And at the same time, the field's roots are community-based. And one of the things, the priorities of the discussion today and the work that we're doing at the Center for Social Development is how do we ensure that the very community-based expertise, perspectives, and work that have brought food as medicine into the moment that it's currently facing aren't lost or left behind, but helping to strengthen the work that's ahead. And of course, you can't just have one Spider-Man meme. We've got another one. So that does bring to mind another adage of with great power comes great responsibility. And we can think about and maybe even reimagine the traditional interpretation and presentation of power, in particular in a healthcare space, and what that means for food as medicine as a connector, as a convener, and as something that we can advance together. So I'd also just briefly like to acknowledge some critical institutional support that WashU centers and institutes have provided advancing mixed method and community-engaged efforts around food as medicine. The Center for Diabetes Translation Research helped to fund an evaluation of a 12-month type 2 diabetes pilot that Food Outreach led. WashU Assert has helped to support a new pilot project with Food Outreach, looking at medically tailored meals as people transition from active treatment to survivorship in cancer. Farm has very generously supported network and ecosystem building around food as medicine in the St. Louis region, and particularly jumping off with a pilot program with Mercy Jefferson that's addressing malnutrition in older adults, malnutrition being one of the fastest growing causes of death in the United States. And ICTS, who's generously invested in Operation Food Search and WashU developing a 5-year shared research agenda and shared strategic plan. All of that work is based at the Center for Social Development, where I'm humbled and honored to be based, and is contributed to, added to, bolstered by, catalyzed by countless community-based institutional partners, to be sure. So with that, my humble job has, I don't want to say it's done. We still actually have the best part of the program coming up. But my job now is to get everyone to offer a rousing round of applause for an incredible group of panelists who are joining us today. And if I could invite the panelists up to the stage. So today is truly about spotlighting local expertise and identifying where there are openings for stronger coordination and impact. Cross-sector community partnership models, what it takes to make food as medicine intervention sustainable, how organizations navigate research and evaluation, and what direction policymakers are going. So with that, welcome to our panelists. I'm going to grab these microphones.
Good morning, everyone. My name is Natasha Woodard. I am the Nourishing Healthy Starts Manager with Operation Food Search. I have been in Operation Food Search for 30 years now. 30 years. Yes, next month. So I'm excited about that. I'm excited to be a part of this community. I'm very grateful and honored. And switch. Good morning again. I'm Amanda Berry, and I'm a food security policy manager at Empower, Missouri. We are celebrating our 125th anniversary this year, advocating for social justice. And I do that with Christine Woody, and we work on all things related to food security policy. Yeah.
Morning, Mark Huffman from Washington University. I'm a cardiologist, and my patients need better tools to eat better, eat more healthy. I'm also a scientist, and I conduct food as medicine research, including clinical trials and evidence synthesis. I'll talk a little bit about that today. So thanks a lot for inviting me to say today.
Hello, good morning, everybody. My name is Gosik. I'm the program director at Food Outreach, providing free medically tailored nutrition services to folks across St. Louis. Super honored and humbled to be here, and thank you all for joining this conversation about food as medicine.
Good morning, everyone. My name is Brittany Jones. I am the Director of Community Driven Innovation and Racial Equity Initiatives for the Panelist Integrated Health Network. And I'm very excited to be here with you all today to talk more about community approaches and inclusivity.
Thanks, everybody. Thanks to our panelists, and we're going to jump right in, and I'll keep it right here with Brittany. And could you just talk a little bit about what does food as medicine mean within your organization, and how has that definition shaped your program, research, or policy priorities? What?
I have a beautiful slide deck prepared for you all today. So a little bit about the Integrated Health Network. We are a healthcare intermediary building capacity across sectors to improve the well-being of community members as well as advancing health equity. Today, I will be talking about IHN's work in co-leading a local community collaborative and how we explore engaging communities and being able to co-create interventions to meet the diverse needs that reflects our region. So in 2022, IHN began co-convening our local community-driven collaborative called Empower Thriving Communities, who is committed to transforming systems that is and empower thriving communities to have abundant access to food and health. The EDC collaborative was established in 2021 during the height of the COVID-19 pandemic, really aimed to support residents with healthy food options, safe spaces for physical activity, and increasing social connectedness. Over the past 5 years of the collaborative's development, we have grown into this hub that is focused on transforming our existing food system to cultivate an ecosystem that is sustainable and community rooted, and building solutions that will address food security, land access, and health and wellness. What's beautiful about our collaborative is that we are driven by local farmers, growers, pantries, food banks, kitchens, and food justice allies. The purpose of this collaborative is to truly reimagine the definition and the experience of food and nutrition security and bolster a region where residents are active participants in shaping their food system. And what's beautiful about this timely conversation today, earlier this year, ETC discussed the essence of the very question we're being asked today. What does food as medicine mean to you? In our meeting, we asked, what does food mean to you and the community members that you serve? And here are some of the themes that came up for us. Themes were expressed around health, comfort, connection, wealth, identity, and freedom. ETC remains unwavering in our vision to create a food ecosystem that recognizes and appreciates all food producers, residents, and allies who are contributing to this work and making sure that we have autonomy and healthy, nutritious, and culturally celebrated food options. We understand and witness that food is holistically medicinal, not just physically, but emotionally, mentally, spiritually, and socially. And so with that, I believe that this is the approach and the commitment that we need to have, and I'm happy to talk more about that today, especially when we're thinking about leveraging food as medicine and we're thinking about sustainability. So this is what food as medicine means to us in the IHN. Thank you.
So at Food Outreach, we believe that nutrition is a source of health, dignity, and hope. For us, food as medicine means combining expert nutritional support through scratch-prepared, medically tailored meals, medically tailored groceries, fresh produce, and medical nutrition therapy provided by our registered dietitians and home delivery services, that are paired with a deeply human approach to care in a community setting. So we deliver nutrition services that support the specific health conditions of our clients, all of whom are living with HIV or cancer while experiencing food insecurity. Our core mission is to support folks living with HIV and those undergoing cancer treatment, but we continue to expand our program to additional diet-related chronic conditions, such as the uncontrolled type 2 diabetes pilot that Dan mentioned earlier at the top of this hour, and congestive heart failure pilot projects. Going back nearly 4 decades, Food Outreach started as a grassroots organization in 1988 during the AIDS epidemic. It was a group of friends cooking meals for their friends who were experiencing wasting related to AIDS. In the 90s, Food Outreach formalized itself as a food as medicine organization by adding registered dietitians to the staff. And then in 2006, cancer was added to the mission, recognizing the super important factor of nutrition in cancer care. So for the past 20 years, Food Outreach has been operating out of our 10,000 square foot facility in downtown St. Louis. And today we serve nearly 2,000 clients across the region each year and continue to build capacity to deepen our role as a food as medicine provider in the region. Most recently, Food Outreach began on the path to become an accredited, medically tailored meal provider with the National Food as Medicine Coalition. Through this process, our entire staff and all of our volunteers work together to really standardize and strengthen our program and demonstrate that we meet the over 200 benchmarks that define a high-quality, medically tailored meal provider. In essence, what this means is that all of the meals provided by Food Outreach meet the established nutrition standards for medically tailored meals while still tasting good, accommodating for dietary needs and preferences, and offering a variety of options from different cultural backgrounds. It also means that our registered dietitians are fully integrated into our program model. They're directing the menu and providing individualized nutrition assessments and support to our clients. It also means that we have strong food safety and operational processes, and that our program design aligns with a nationally recognized food as medicine model that is supported by decades of research related to improving health. But what food as medicine really means is that we're supporting our clients to get the nutrition that they need to feel better at what is oftentimes a really, really tough time in their life.
Good morning. Later today, I'm going to be in clinic, and I've been a cardiologist for 15 years, taking care of people who all of us want to live a healthy, productive life. And yet they struggle. That's what some of the reasons why they come to me, is that they have problems, but as a preventive cardiologist, so they might come because they're interested in trying to prevent the development. So no doubt, diet is central to our discussion. It's one of the 8 metrics for cardiovascular health according to the American Heart Association. And unfortunately, most patients who I see struggle to eat a few, let alone the 5 to 7 recommended fruits and vegetables every day. And you can imagine what that does over a lifetime related to things like blood pressure, cholesterol, body weight, glucose, and then the development of different forms of heart disease. But even when they have heart disease, we know food is medicine, food is central to that treatment. So it's not just about, but it's can be powerful in describing about patients with heart failure. Well, I'm going to see some patients suffering with heart failure. But as a scientist, I also want to think about the reliability of that evidence that for the recommendation that I make. So patients will frequently come to us about maybe leading edge things that aren't really not sure about. And I say, you come to me for reliable advice. Say, for example, your blood pressure medication. So to strengthen your heart for heart failure, to lower your cholesterol. And so we use high quality evidence, which means that future research isn't likely to change when we think about that. This is likely to have this effect on your blood pressure, this effect on your cholesterol. And to generate that evidence requires a lot of work. Scientists perform randomized controlled trials that give us the most reliable evidence, the closest to truth, of understanding, will this work? And I say to my patients regularly in clinic, we're trying to do impossible things together. We're taking group level information from the past to apply to you as an individual today to predict a brighter future. That's hard to do. You don't have crystal balls. So we have to use your values and preferences and how you want to be treated. And so that same rigor, I believe, needs to come to the food business. Yes, food is important. We've got the high quality evidence showing the benefits, but how do we deliver that and integrate that? My colleagues and I desperately want and need better tools to provide not just advice to patients, which does improve fruit and vegetable intake by about 1 serving per day, but better tools so that that can be integrated into their health insurance, their health plans, policies, and incorporating things like medical nutrition therapy. So we, as you all know, if you've been to the doctor, we use electronic health records, and that's changed a lot of the relationship with doctors and patients. And it's changing really quickly now with the advent of artificial intelligence, how we get to interact. And dinner last night with a visiting professor, and I said, what do you think the identity of physicians is going to be in this era of artificial intelligence? And there's a lot of fear about these relationships. And he referenced the book I Thou. I'm talking about, do you see God in others? You see that person across from you, the care that our job as physicians is to provide and to heal. And so we need better tools to be able to do that. We know that food is medicine, but oftentimes we don't have an ability to that order in. We don't know where to plug in. So I'm very excited to be meeting people here today to think about that. But I also want to generate the evidence base. I'm funded by the American Heart Association, along with Jane Lee from Tropical Nutrient Act, which really look at trying to deliver food as medicine within the BJC health system. We have a lot of barriers in that study to recruiting people, because we all know trust is incredibly important. And people aren't sure about food as medicine. Who is it? What are you talking about? Free food? What are you talking about? This vendor? I've never heard of it. So we were working the show, so that obviously helps a lot for. But as this ecosystem builds, it's going to be important to understand how we connect with people that understand what the delivery of the services will look like, how people feel about that. I also have a project that I co-lead called Impact FIM, and we're really trying to harmonize and synthesize food as medicine randomized trials so that we can generate reliable evidence. So we've got about 50 trials from 30 institutions that are part of our consortium. It's the first of its kind, largest happening. And we're excited because the investigators have done a lot of smaller scale projects generally. There's a few larger ones. And we want to be learning from one another, working together so we can have, again, more reliable evidence. So that when policies are in place to fund food as medicine research or food as medicine practice, the expected benefits will be observed rather than hoping that those benefits will be observed. They're unreliable. And the field is moving quickly. So we have about 50 trials currently. There's 200 that are going. This field is exploding and it's going in a lot of different directions. So we need some structure to be able to harmonize and ultimately synthesize this research. So thank you very much for inviting me, and I hope look forward to your questions and discussions. Thinking about this practice of food as medicine and the science of disease. Thank you.
Now I had to follow this. So for the Nourishing Healthy Starts program, food as medicine means recognizing access to nutritious, culturally relevant food as a critical component of maternal health care and overall well-being. We view food not simply as nourishment, but as a preventative and a therapeutic tool that can improve birth outcomes, reduce stress, support mental health, and promote healthy pregnancies and families. This definition has shaped our program and policy priorities in several key ways. The first one is addressing food security as a health issue. We integrate nutrition support directly into services for pregnant and postpartum participants, recognizing that inadequate access to healthy food can contribute to poor maternal health and infant outcomes. We also provide consistent access to nutritious foods through partnerships, and we provide bi-weekly food box deliveries to folks' homes that are in our program. We also receive fresh produce, healthy food options, and resources that support long-term food security. We also combine food access with education. So participants receive monthly nutrition education classes on site, cooking demonstrations, recipes, and practical strategies that empower them to make more informed food choices for themselves and their families. We also support the person as a whole. So we not only are addressing food access, but we're also teaming them up with maternal health advocates that are assigned to them. Recognizing the connection between nutrition, mental health, stress reduction, and healthy birth outcomes. Food assistance is paired with the care coordination. We provide resource referrals and supportive services that address the broader social determinants of health. We also elevate participant voice and lived experience. We do this by participant feedback, ensuring that food offerings, educational content, and support services actually reflect the participants' needs and their families, the preferences and cultural traditions of the families that we serve. We also advocate for systems level change. Our policy priorities focus on increasing equitable health access to healthy foods for pregnant and postpartum individuals and strengthening community-based maternal health programs. We promote investments in preventative approaches that address not just food security, but also the person and the family as a whole. Through NHS, food as medicine is not a single intervention, but a comprehensive strategy that we utilize on a daily basis as a way to prevent approaches in terms of addressing food security before it leads to more significant health challenges.
I also have some maths. Hopefully. All right, so Empower Missouri doesn't do programs, we do policy. And to my knowledge, all of the food as medicine programs are grant funded. And there needs to be a mechanism to make this more sustainable. Sometimes that can be done through legislation. So we're going to talk a minute about the Food as Medicine Act, aka House Bill 2372. So this legislative session, which began in January, there were actually 3 standalone food as medicine bills filed. And then in the very end, the language got added to a healthcare omnibus bill that was hundreds of pages long. But the food as medicine section got added into it. And this is the actual language that was passed this session. And it directs the Department of Social Services in Missouri to apply to the Health and Human Services at the federal level for a Section 1115 demonstration waiver, which will implement the Food as Medicine program for the purpose of providing nutritional support through the MoHealthNet, aka Medicaid. The Food as Medicine program shall be designed to improve health outcomes for MoHealthNet participants with nutrition-related chronic diseases through nutrition services and to reduce the need for medical care to those participants. Within the bill, it covers the following services: case management, so they can go and see their provider and get some nutrition education, etc. Ongoing care, monitoring if it's being effective or not. Nutrition counseling and food provisions prescribed by a registered dietitian, a physician licensed under Chapter 334, not really sure what that chapter is, but, or a qualified clinical team, including medically tailored groceries, medically tailored meals, and produce prescriptions. And all of those would now be covered under Medicaid. Something very important and rather unique and innovative, I think, is that in our bill language, it actually includes this. And it says, whenever feasible, the MoHealthNet division shall prioritize the inclusion of community-based organizations and local growers to support the purchase of locally grown food in nutrition prescriptions. And this is important because when we buy local food, it actually has an economic multiplier between 30 cents per dollar and 90 cents per dollar. So it's a very good thing. If you're interested in this advocacy, and the reason why, so we have the bill and it says that the department may apply. We didn't need legislation for this to happen. The Department of Social Services could have at any point in time done this. Having legislation says that Missouri is serious about it, but it will take all of us to still get this done. They could sit on it forever. So we do have a statewide Food as Medicine Coalition, Trina Reagan, whose name's already been mentioned today. Just recently is going through the process of formalizing that. You can participate in that to help us get that through, to draft the waiver and get it submitted ultimately to the feds. And then I just wanted to also share there is some federal work being done on this, and it's called HR 8355, the Accountable Produce as Medicine Act. It's not really new, but it has been filed, and it's something worth noting that the feds are also working on this. And then here's some QR codes if you are interested in joining the Food as Medicine Coalition. Is on your right, and the Food Security Coalition, which I co-lead, is on the left, and we talk about these kinds of issues as well. Thank you.
So we'll do a little bit of a, I would call it a lightning round, because we're never behind, we're always ready. But in order to just keep things moving, we'll have kind of short responses to a couple of questions that we wanted to kick off that move into audience streaming. So first I wanted to ask Sydney, if you got right nearby. So medically tailored meals for food outreach requires significant care and coordination. healthcare registered dietitians, volunteers, food suppliers, delivery drivers. What's been required for food outreach to develop and sustain those relationships? Okay.
Yeah, thanks, Dan, so much. So yes, sustaining these programs requires deep coordination between everybody that you mentioned, and ultimately trust between our staff of just 18 staff members, all of our volunteers, our food vendors, our referral partners, of which there are 60 plus different healthcare sites across the region, and countless providers who refer patients to food outreach, and of course, the trust of our clients. What I think really keeps these relationships working is staying centered on the client experience and knowing that our program makes a real impact on someone's ability to manage their treatment, to maintain strength, and to improve their health and quality of life. One thing that I think makes food outreach successful is that we continue to surround ourselves with people and partners who really believe in the power of nutrition. So I want to shout out the food outreach team over there at the table in the back. Raise your hands, yeah. So internally, our team is made up of an intake coordinator and 2 registered dietitians. We have a culinary team, including a head chef and assistant chef, an operations team that works with our client services, sourcing, delivery drivers that collaborate endlessly to make sure, one, that our menu is clinically appropriate and responsive to client needs, that the food we offer tastes good and is consistent and high quality, and that our clients are connected to services quickly and get the support that they need, even if sometimes it is beyond food. And that we're operating responsibly within a budget. It's been mentioned that a lot of these programs are grant funded, and even as food costs continue to rise and the need for our services grows, we're always bringing together funding, we're analyzing costs and looking at sourcing, and we're looking for new opportunities to expand our work. And I would be remiss to mention this, we rely on an incredibly dedicated volunteer workforce who cook and pack all of our meals and work in our grocery center to fulfill our client orders each and every day. Our volunteers are equivalent to 9 full-time employees each year, and they truly are the cornerstone of our model and our client experience. And then externally, our healthcare partners, they need the confidence that we are delivering a nutrition intervention that is evidence-based and supports care plans. So although we're not directly a healthcare provider in the traditional sense, we believe that our program really is critical to supporting healthcare and those care plans. And because we're a community-based organization and provider, we have that kind of separation from the clinical setting and can really engage deeper with folks related to their diet, the symptoms they may be experiencing throughout treatment, and the nutrition topics they really want to learn about. And so I'll end there to keep it brief. But yes, deep collaboration and trust between all of the partners involved.
Great, thanks, Sydney. And speaking of deep collaboration and trust, I want to move the next question to Brittany and ask about what does a community-driven approach to food justice and health equity look like in practice, connecting between your work, healthcare, and the local food producers like?
Absolutely. So for the work for the IHN, what we like to do is make sure that we're centering and also being led by our community partners. And I want to have an emphasis on the led by piece because I believe oftentimes within research, we talk about centering community voice and experience, but what does that truly mean? So within the ETC collaborative, our collaborative is led by our local food producers. Everything that we design, everything we do, our activities, our strategic plan that we're finalizing is led by our local food producers. And what's beautiful about that is many of our food producers are residents themselves of the communities that they're serving. So they know exactly what community wants, they know exactly how community wants to live. And so the programs and services that they're developing is a direct response and informed by community. And to your latter point, Dan, when it comes to integrating healthcare systems and other organizations, we intentionally have our collaboratives to be inclusive to what we call food justice allies. And those individuals are encompassed of our local healthcare systems, of transportation organization, of our city and county departments of health, to make sure that we are truly building a bridge between food, between community and clinical integration, and really thinking about how do we integrate food within our healthcare plans, health-based interventions, and goals.
Thank you so much for saying more about that. Natasha, you did such a nice job introducing the Nourishing Healthy Starts program and talking about a holistic, comprehensive approach to food as medicine. Just with an eye on the clock, could you kindly, without putting you too much on the spot, identify maybe one challenge and one benefit or one strength of the approach that Nourishing Food Research takes with Nourishing Healthy Start that you've observed working so closely with families?
Sure. Let's see. One barrier, I believe, being able to get, okay, so we have our teaching kitchen that we provide our cooking classes for and our nutrition education classes. Excuse me, but one of the things that I feel will be beneficial is being able to have more people to actually come to the classes. We have to limit it depending upon, you know, our kitchen space, right? So we have to be limiting in the amount of people that are actually able to come to the classes. One thing that I would like to see us be able to do is be able to open it up a little bit more to have, for more people to have access to the cooking classes and to the nutrition education piece. One of the things also that has worked very well is we actually value and utilize participant feedback. Brittany was speaking to that earlier. I think that that's something that's been really, really crucial and critical in the development and the involvement, how our program has actually evolved. So yeah, those are some of the things that I believe would be beneficial and helpful as we continue to grow the program.
Natasha. And Mark, your work brings both critical, clinical, and global lenses, which we haven't talked about quite as much this morning. But what do you think is one thing the St. Louis Food Medicine ecosystem does well that the broader field can learn from, and vice versa? What's one thing that St. Louis could learn from the broader ecosystem?
We have this room full, tells me there's tons of enthusiasm in the organization, hearing about different groups that are participating to speak from Mosaic, about places benefit from understanding. So that's, you know, my summary of this to disseminate to others so that they can understand what's in fast. You don't get the word out, otherwise just figure it out on their own. I would say that we're trying to bring experiences from other high quality research teams to St. Louis so that there's a template. There's all kinds of different participants, people, you know, maternal cardiovascular health, people with diabetes, people with overweight, obesity, like just the inclusion criteria. Then you think about all the details of the different types of foods, like those big buckets. But then what about all those details within those buckets, that foods themselves, and then measuring the outcome? So I would think that we would be in better stead to be using or aligning with higher, you know, the highest quality protocols, so that you're more likely to generate evidence that, you know, provide services that it's going to give you better results. You should know what that will look like rather than what we hope that this. Don't want to have to food strategy.
Thank you. And last but certainly not least, Amanda, what's one lesson learned or reflection from this past legislative session in Missouri that you're carrying forward with you that you share with the room and everyone tuned in online? Something that surprised you or something that we're carrying forward in terms of how to engage policymakers around food as medicine?
An insane amount of hype. So passing legislation the first year it has ever been filed, especially when it's a good bill, like just does not happen. We had advocates from all over the state that came to every single hearing, which I think there were like 6. It was a lot of hearings. And the legislators were on fire. We had almost no opposition. It was just very supported. And that was surprising because outside of our coalition, like we had no idea that this was going to be supported that way. And the second part of that question was?
Something we're carrying forward.
Something we're carrying forward. Work does not stop. It takes a sustained effort, long term, and we're going to get it done. And you're welcome to join us in this, but we will get it done.
Thank you so much. With an eye on the clock, happy to open it up to questions from the audience. Don't be shy, put those hands in the air. All right, here in front.
Hi, I'm Justine from Fund Admission, and I'm wondering how MAHA affects your work or local state policy or funding. If there's any positives coming out of it for us here in Missouri.
All I can think of is HR1 and it like decimated SNAP. So I'm gonna maybe to somebody who has.
I think there's a greater awareness of the potential harms of ultra processed foods and the importance of healthy eating as being foundational for health. So that's good. That's a good discussion for us to have. There have been some limitations. CMS's MAHA Elevate program does not allow for provision of food. So, despite putting like a major grant program, there's a uncertainty on the details of what will be implemented. So, it's a good overall message about healthy eating being foundational. I think that there's widespread agreement on that, but not a lot of opposition. But these Ambrose would say that things are take eyes and the details. Let's see what the details.
Pyramid effects. What the knowledge.
No comment on the food pyramid. But appreciation for the momentum that there is related to food and food as medicine, and hopefully funding sources will open up because of that.
Other questions?
Can you hear me?
Thank you, right? Well,
I'm
that's
sorry,
the
can
question
you-
coming from above?
Can you hear me?
Yes, we can hear you now.
Oh, I'm sorry. So I am a family nurse practitioner. So what kind of qualifications or certifications would somebody like myself need to be able to help people in this realm? Because I'm very interested in the topic. I'm not a registered, I guess what I'm saying is I'm not a registered dietitian, but I would still love to be a part of it or help with it.
So referral for, say, medical nutrition therapy would be something that many diagnosis fields that would be a lot, reimbursed essentially. And some of the questions that we're talking about is how do you go beyond medical nutrition therapy? And there's often linkage to community-based organizations hearing about. And that challenge often, I'm not sure what system we might use, but like, I don't have ethic watershed to be able to do that at the coach but so a busy clinical encounter. We're talking about but I'm going to need some additional support because I'm supposed to do the cardiology stuff that only I can do. But I know that that's critically important too. So hopefully you might have a team that you work with, but probably starting with medical nutrition therapy, I can watch through how I do it in my practice. And I'm sure other people here will be willing to, partner with you as well for your patients.
That would be great. So how do I connect with someone about this?
Through Dan.
I'm sorry, it's
It's my cell phone number in the chat.
okay, perfect. Thank you.
Thank you. My question is actually for everyone. Mark, maybe I start with you. All of this food as a medicine as a foundational belief obviously has great, it's been established that the challenge is innovation in distributing, implementing and scaling that. So my question is really related to in all of the world or in this country, some of the very evidence-based that demonstrate that could work. How can we bring those to the region to scale and implement and scale? And are you aware of any of those that actually we should learn and implement? You mentioned the standard, but other things. My second following is for everybody here is locally some of the innovation that already have been producing results. How can we focus on scaling?
Sure, thanks. I'll be quick. So the field of dissemination implementation science tries to understand what the determinants and strategies are for the implementation and scale up of evidence-based interventions. So good practices. So this would be the sort of challenge that scientists like here and lots of other people are trying to figure out. Large trials based on Paris Permanentes would be pulled up as a great initial study, about 1,200 participants. And Alan Doe is the chair of our scientific committee. He's the investigator of that trial. And our hope is to do more of a multi-state trial. Kaiser is a very unique system, and they have a lot of internal motivations to keep their costs down, especially with the widespread growth of GLP-1 receptor agonists for weight loss and cardiovascular population. And so thinking about, Kaiser's incentive is, we're gonna go bankrupt, cannot afford, but once the scale of the need is beyond just trying to drug your way out of this, it's gotta be much earlier in the prevention sector. So, yeah, my hope is that we can, so we have people like Alan on our board, so that we're learning from the very best in these types of trials. Getting together as a collective in this region is challenging for research. BJC's been a terrific partner. We work with care case group for Orange Hospital, but working across systems, that's harder to do. It's possible, but hard.
Yeah, I would also add to that, investing in the infrastructure for community-based organizations like the ones up here that are been doing the work for many decades and have the knowledge and expertise to really deliver. But that can only be scaled when you invest in the infrastructure and all of the resources that it takes to really deliver these programs, especially when you're thinking about taking on many, many patients who would benefit from that access to programs like food outreaches and Operation Food Searches. Because the benefits of these programs really only come from the experience that the patient has, that the client has. For these programs to be successful, you first have to get people to engage with them. You have to get them to utilize them. They have to eat the food. They have to cook the meals. They have to meet with the registered dietitians. And then we can start to measure outcomes. And so when we start to invest in kind of the trusted community-based providers, I think that's when we'll really see the scaling and the impact at the regional level.
And just to add to what Sydney's saying, I appreciate all the excitement around food as medicine. And also something I really want to drive home today is the concept and the practice of using food as medicine is not new. It is in fact communal and ancestral to many organizations and community members, especially communities of color or communities with a local majority. And so that's why with ETC, we really lean on our partners. We have partners who provide medically tailored meals, partners who are implementing gardens within schools and churches, partners who are doing physical wellness classes, and even teaching about herbalism and how the body functions. Those are all key components that create a movement for food as medicine. And it's not just providing the food that we've been sharing, but it's about giving community members the tools, the education and civic engagement to be able to sustain and create generational change. And so I believe that that's the way that you scale while we're thinking about exploring the expansiveness of what food as medicine is and who are the producers and how they coordinate together.
I just wanted to throw in that I think long-term sustainability for scale will require insurances covering the service. Yeah. I agree with everything that was stated, but then I also want to interject that food as medicine currently focuses on those with chronic disease. And I believe that we also need to include maternal and infant health in that. So I'm hoping that what we're doing as at Operation Food Search with our program, as well as our NHS Together, where we're actually providing food to working with other organizations, where we're providing the food aspect to people that they currently work with as well. So that's one of the things that we're looking towards.
Just with an eye on the clock, I wanted to give people time to make their way slowly to the stage or kind of rush the stage. Talk to these amazing panelists. We get one more round of applause. Thank you again to the Clark Fox Policy Institute for the generosity and helping to convene and bring everyone together this morning. This isn't the beginning for food as medicine in St. Louis or more broadly, and it's certainly not the end. So we're really looking forward to being this really critical juncture and building more connection, connectivity, connectivity, capacity for all of those in the room. So a quick plug. So a quick plug, QR code here. Please join us for the next Senior Policy Fellows event, Federal Cuts, Local Consequences, how St. Louis can respond to an unraveling safety net. Be amazed by the speakers there. If you're online, if you could please be on, that would be amazing. Thank you. Adam Pearson, Stephen Roll, Kristen Wild, so some familiar names, faces, other people I'm sure I'm forgetting. My apologies to those people. And thank you for joining us. The Clark Fox Policy Institute, again, is doing incredible work. This is one of a series of events like these. And so your feedback on this event and the work that we're doing more broadly is truly appreciated.